You know the feeling. You're sitting in the doctor's office, and that paper gown is crinkling every single time you breathe.
Yeah, the classic paper gown.
Right, and your neck hurts, or maybe you found this weird lump on your jaw. And the doctor walks in, looks at their clipboard, and just asks, "Hey, do you happen to drink tap water?"
Which just feels totally out of left field.
Exactly. Just want to look at your neck, so why are they talking about your plumbing?
I mean, from the patient's perspective, it definitely feels like a distraction. Or, maybe just a doctor blindly filling out some mandatory corporate form. But from the clinical side of the desk, it's a highly targeted investigation. Well, it's pure diagnostic logic.
And that is exactly what we're getting into today. Welcome to our deep dive. We are looking at a set of actual clinical study notes that are used to train medical professionals on taking a patient's history, specifically for the ear, nose, and throat system, or ENT. Our mission today is to sort of decode the hidden logic behind that clipboard. We want to show you how a doctor actually works as a medical detective, using these seemingly random questions to pinpoint the exact issue you're facing.
And honestly, the most fascinating part of these notes, at least to me, is how they teach doctors to look for the negative space.
Negative space? Like, what isn't there?
Exactly. The absence of a symptom is frequently just as revealing as its presence. I mean, asking the right questions helps filter out the terrifying possibilities, right? And it lets them zero in on what's actually happening in your body.
So to really understand that filtering process, we kind of have to look at how doctors evaluate a single specific problem before we zoom out to the rest of the body.
Yeah, you have to start small.
Right. And the notes start with a classic scenario. You have swelling or a lump on the side of your face, specifically the parotid gland, that's that major salivary gland just in front of your ear.
Yeah, and rather than just, feeling a lump and guessing, doctors are trained to map it out. They use this grid of very specific questions. There's this mnemonic. They use double PSI PAT test.
Our PSI PAT SR, that is a mouthful.
It is. But let's break down the DOPSI part first. They want to know the duration and the onset. But not just, hey, when did it start? They need to know, did you notice it first, or did someone else point it out to you?
See, I thought that was a brilliant piece of diagnostic psychology. Asking if a friend or a spouse noticed it first. It's kind of like a scratch on your car, right?
Oh, that's a good way to put it.
Yeah, like if you drive that car every single day, you might not notice a tiny gradual dent because your brain just normalizes this slow change.
Right, you just get used to it.
Exactly. But a friend who hasn't seen the car in a month, they spot it instantly.
That's exactly it. If someone else noticed your lump before you did, it tells the doctor the progression is incredibly gradual. And slow, insidious growth often points to something benign, or, perhaps a slow-growing mass.
As opposed to waking up with it.
Right, if you noticed it suddenly, like overnight, we're likely looking at an acute infection or rapid inflammation. It changes the whole trajectory.
And then the notes push further into the PAT part of the mnemonic, specifically what aggravates the lump. They ask about trauma, coughing, and then randomly spicy food.
Yep.
So wait, a spicy taco is essentially acting as a natural stress test for your salivary gland.
Precisely, because remember, the parotid is a salivary gland. So when you eat something spicy, your nervous system tells that gland to kick into overdrive. It needs to pump out massive amounts of saliva to cool your mouth down.
Okay, that makes sense.
But if you have a blockage in that duct, like a tiny salivary stone, the gland is trying to push all this fluid through a closed pipe.
Oh, ouch.
Exactly. The gland swells up rapidly and painfully. It's a textbook mechanical obstruction.
Wow. And I also noticed the notes really emphasize using localized language. Like instead of asking if a patient has cystic fluid fluctuation, which sounds terrifying.
It really does.
The notes remind the doctor to ask if they have a feeling of water in their mouth, using like the local dialect.
Because medical jargon builds walls, Translating these complex physiological concepts into a relatable lived experience, it ensures the doctor and the patient are actually solving the same puzzle.
That's a great point. But, a local lump rarely stays a local story. The clinical notes don't stay focused on the face for long at all. The diagnostic logic quickly branches out to totally different parts of the body.
Yeah, the web gets wider.
It does. We go from checking a swollen jaw, suddenly looking at the scalp. Why?
Well, because the body isn't just a collection of isolated parts, right? It's an interconnected ecosystem. A swollen gland is frequently just the canary in the coal mine for systemic disease. They use another mnemonic here. FEOs checking for facial palsy, ear issues, oral cavity hygiene, and scalp ulcers.
And the notes explicitly link that parotid lump to conditions that affect the entire body, right? Like rheumatoid arthritis, gout, and Sjogren's syndrome.
Yes, and Sjogren's is actually the perfect illustration of why we have to zoom out. Sjogren's is an autoimmune disorder where the immune system mistakenly attacks its own moisture-producing glands.
Oh, wow.
Yeah. So if a patient comes in with a swollen salivary gland, and the doctor only treats that one gland, they miss the underlying disease entirely. But by asking, have you noticed your eyes feeling gritty or your mouth constantly dry, they connect the local symptom to the systemic autoimmune attack.
Okay, but put yourself in the patient's shoes for a second. My jaw hurts, and my doctor is suddenly asking me if my eyes are dry, or, and this is actually in the notes, if the bottom of my foot is numb.
Right, the sural nerve check.
Yeah, I'm gonna think they've completely lost the plot. How does a doctor bridge that gap in the exam room without annoying or just totally confusing the patient?
It's a really common issue, and it requires narrating the clinical thought process in real time.
Like talking out loud while you work.
Exactly. If a doctor asks about foot numbness, they're checking for peripheral neuropathy, which is nerve damage at the farthest edges of the circulatory system.
Okay.
So conditions that cause widespread nerve damage, like severe diabetes or certain autoimmune pathways, well, they can affect both the nerves in your extremities and the nerves controlling your facial glands. A good doctor will say, look, I'm checking your feet because sometimes the process affecting your jaw also shows up down there. It turns the patient into a co-detective.
That is so smart. And the notes also require checking for frequent urination and excessive thirst, which are, those classic diabetes markers.
Exactly.
They also flag specific medications like oral contraceptives, which can chemically alter glandular function. It's really all about context. And if the swelling is lower down, like under the jawline and the submandibular gland, the notes completely shift the context to dental pain and nosebleeds.
Because anatomical proximity is key right there. The roots of your lower teeth sit right above that submandibular area.
Right.
So a deep infection in a molar will frequently drain downward, and that causes the submandibular gland to swell. The tooth is the root cause. The swollen gland is just the collateral damage.
Okay, so once the doctor has mapped these outer glands, the notes sort of guide them inward, down into the throat and into the mechanics of swallowing. And the questions go from these broad systemic checks to hyper-specific physics.
The throat is a really high-stakes intersection. I mean, you have air, food, and liquid all trying to pass through a very tight, highly coordinated space.
Without crashing into each other.
Exactly. And when that coordination fails, the specific nature of the traffic jam tells you exactly where the system is breaking down.
Take breathing difficulty or dyspnea. The notes don't just ask, hey, do you get out of breath? They want to know if breathing is noisy, if it's worse when you're lying flat, and exactly how many steps or stairs you can climb before it triggers.
And asking about the number of stairs is crucial. It's a way to objectively measure a highly subjective feeling.
What do you mean?
Well, I get out of breath easily means two entirely different things if you are a marathon runner versus, a couch potato.
Oh, right. Very true.
But I can only climb 5 stairs before I have to stop. That is a standardized, trackable metric. It gives the doctor a hard baseline to see if your lung capacity is deteriorating or improving over time.
That makes total sense. And they apply that same precision to dysphagia or swallowing difficulty. They need to know if the trouble is with solids or liquids. Does the food need extra chewing? Does it stick? And they even ask if there's a lump feeling in your throat specifically between meals.
Yes, the globus sensation.
Right, and a lot of this points straight to acid reflux or GERD.
Right, absolutely. Acid reflux is a massive, often silent culprit in ENT issues. The stomach acid basically comes up and burns the delicate tissues of the esophagus and larynx. It causes chronic swelling, hoarseness, and that persistent sensation of a lump even when you aren't eating anything.
Now, here's the detail that completely blew my mind. When evaluating that reflux, the notes explicitly instruct the doctor to ask if the patient is bringing back up digested or undigested food.
Oh.
That is such a specific mechanical timeline.
Isn't it? It's pure structural engineering. Think about it. If you regurgitate digested food, that means the food made it all the way down into the stomach, it mixed with gastric acid, and then it escaped back up.
Okay, so the door at the bottom is broken.
Right. It tells the doctor the sphincter valve at the bottom of the esophagus is loose. But if you bring up undigested food that looks exactly like it did when you chewed, it means that food never reached the stomach.
Wow.
It points to a structural blockade or a pouch higher up in the throat, like what we call a Zenker's diverticulum. It essentially catches the food in the esophageal wall before it can even complete the journey.
That is wild. And once the doctor understands the mechanics of your swallow, they immediately look for the consequences of those mechanics failing. This is where the clinical notes move from, structural issues to flashing red warning lights.
Oh, definitely. In every medical history, doctors are constantly scanning for red flag symptoms. These are the clues that indicate we aren't just dealing with a benign cyst or a temporary inflammation, but potentially something life-threatening that requires immediate intervention.
And the first major red flag category here is aspiration. The notes highlight choking while eating, coughing, noisy wheezing, and crucially recurrent chest infections.
Aspiration happens when food, liquid, or even your own saliva goes down the wrong pipe. Instead of traveling down the esophagus to the stomach, it slips past the vocal cords and enters the trachea, heading straight for the lungs.
Which is bad news.
Very bad. The lungs are a pristine, sterile environment. If you drop food particles or oral bacteria down there, it causes severe destructive pneumonia. So if an ENT patient has a history of recurrent chest infections, it's a massive red flag that their swallowing mechanism is fundamentally broken. It's failing to protect their airway.
Another urgent category the notes cover focuses on NITs, or the spread of cancer. The warning signs they look for are rapid weight loss, swelling in distant lymph nodes like in the armpit or groin, coughing up blood, and waking up drenched in night sweats.
This really shows how context alters a symptom entirely. A hoarse voice on its own might just be a vocal strain from, singing at a concert.
Sure.
But a hoarse voice combined with a 15-pound weight loss and drenching night sweats. The diagnostic pathway instantly shifts from vocal rest to rushing tests for a malignancy or maybe a severe systemic infection like tuberculosis.
Right, it completely changes the urgency. Now, going back to fluids for a second, the same gravity that forces food into the wrong pipe during aspiration is actually used as a diagnostic tool for headaches, which I found fascinating. The notes provide this literal map for pinpointing sinus issues based entirely on where and when your head hurts.
It's like a pressure relief valve system, where the pain spikes tells you exactly which valve is stuck closed.
Exactly. So according to the notes, if your headache is aggravated by bending forward, the doctor suspects the maxillary sinus, which sits right in your cheekbones.
Because gravity is doing the diagnostic work there. When you bend forward, the fluid in those cheekbone cavities sloshes and presses against the inflamed front wall,
causing an immediate spike in pressure and pain.
You got it.
And if the pain is localized right between your eyes, that points to the ethmoid sinus. If the pain is deep in the back of your head, they look at the sphenoid sinus. And morning headaches, those point to the frontal sinus in your forehead.
It's incredible, right?
It is. The location of the pain is drawing a literal map to the blocked cavity. And they use that same logic for epistaxis or nosebleeds and coughs. They're looking at the frequency, whether the blood is fresh or clotted, and whether cough is dry or producing infected mucus. They're looking for the story the fluids are telling.
Exactly. Because a single fresh nosebleed in dry winter air, that's one story. Repeated heavy nosebleeds with dark clots, that might indicate a vascular tumor or a serious underlying clotting disorder.
So what's truly fascinating to me is that on the final page of these clinical notes, the doctor completely abandons the physical symptoms.
Yep.
They stop asking about lumps, swallowing, and sinus pressure. Suddenly they're asking about your home, your family life, and your daily habits. I mean, why does an ENT specialist need to know your real estate history?
Because a patient does not exist in a vacuum. Your health is largely a byproduct of your environment, your history, and your daily routines. We call this the holistic patient view. You just can't fix a localized problem without understanding the ecosystem it lives in.
And the notes break this ecosystem down into several histories. First, there's the past medical and surgical history checking for things like asthma, heart disease, past tumors, or radiation exposure. Then specific drug histories. They actually highlight amiodarone, which is a heart rhythm medication, and intravenous iodine contrast, which is used in CT scans.
Yeah.
Both of those are explicitly linked to thyroid and parotid gland issues.
It is incredibly common for a treatment in one part of the body to cause a crisis in another. Take amiodarone, it's heavily packed with iodine, and your thyroid gland uses iodine as the primary building block to manufacture hormones.
Right.
So giving a patient that medication can completely overwhelm the thyroid. It triggers massive dysfunction that might first present simply as a swollen lump in the neck.
Wow. They also dive into personal history, sleep, appetite, allergies. But the socioeconomic history is where it gets incredibly granular. The notes instruct the doctor to ask about the number of family members, the number of rooms in the house, whether the home is well ventilated, and crucially, bringing it all back if you drink boiled or tap water.
The tap water question.
Yes. The doctor goes from asking if your headache hurts when you bend forward to asking how many rooms you rent and if you boil your water. It's basically a complete biography.
And it has to be a biography. Because environmental factors are frequently the root causes of the systemic diseases we see in the clinic. Take the question about the number of rooms in the house. If a patient comes in with a persistent, suspicious neck lump, and we suspect tuberculosis, which frequently causes swollen, matted lymph nodes in the neck, we absolutely need to know their living situation.
Because TB is airborne. Right.
Right. If that patient lives in a crowded one-room apartment with poor ventilation and 6 other people, not only are they at high risk of having contracted TB, but their entire family is now at massive risk.
That is so heavy.
It is. And the tap water question functions the exact same way. In many regions, unboiled tap water is a primary vector for recurrent parasitic or bacterial infections, and those manifest as chronic throat or digestive issues. You can prescribe all the antibiotics in the world, but you can't cure the patient if you send them right back home to drink the exact same contaminated water.
You have to treat the root cause, not just the physical symptom. And the notes drive this home with a highly specific requirement for thyroid evaluations too. If a patient is being checked for a thyroid issue, the doctor must pivot and take a full obstetric and gynecological history.
Yes.
They need to know about pregnancies, miscarriages, normal deliveries, and cesareans.
Because the thyroid governs your body's metabolism, and it is intimately physically tied to the reproductive endocrine system. Severe thyroid disorders can be the hidden cause behind miscarriages and infertility.
Oh wow, I had no idea.
Yeah, and conversely, the massive hormonal shifts required during pregnancy can trigger dormant thyroid issues. The two systems are in constant conversation with each other. You simply cannot evaluate one without understanding the status of the other.
It is just incredible to see it all laid out like this. We started this deep dive looking at a simple localized lump on the side of the face. And by following the clinical logic of these handwritten notes, we ended up mapping out the patient's entire living situation, the ventilation in their apartment, the function of their reproductive system, and exactly what happens when they eat a spicy taco.
It really is quite a journey.
It shows that in medicine, truly everything is connected.
It is. Good medicine is rarely about jumping straight to high-tech, multi-million-dollar scans. It is about the conversation. It is about asking the right questions in the exact right sequence to build that web of clues. The clipboard isn't a barrier between the doctor and the patient, it's a map.
The clipboard is a map. I love that. So here's a thought for you to take away from our time today. Next time you're sitting in that doctor's office wearing that crinkly paper gown, and they ask you a question that seems totally out of left field, like whether you prefer hot or cold water, or if you ever feel a lump in your throat specifically between meals, don't just brush it off or roll your eyes. Ask yourself, what invisible puzzle are they trying to solve right now? What hidden connection is your body trying to reveal? Until next time, thanks for joining us on this deep dive.